Kia ora, Jess. I did do my intro before, but I didn't do it in Te Reo Māori. So ko au, ko mangopi ko te maunga, ko auro te awa, ko te reo mihi me wauro nā marae, ko Ngāti Kuri te iwi, ko te rarawa, ko te apori, ko Ngāi Takato, ko Ngā Pui, ko Ngāti Whātua, ko Tainui aku iwi, ko Jerry Norman tōku papa, ko Whai Norman I te tōku mama, ko Lance Norman taku ingoa. So I'm Lance Norman. I descend from the furthest tribe up north. It's about 14 hours drive from here and 6 hours drive from Auckland. And I've been on this journey for the last couple of years and continuing on. But today I'm going to talk to you about the cultural component of healthcare homes. So before I get into it, there's three key components. There's effectively business efficiencies, which we've had speakers talk about this morning. And what I like about creating business efficiencies is you can go and get more staff to do more recalls to look after all the whānau who aren't coming in. We also talked about clinical efficiency. On that same process, hopefully we can get more staff and then focus on some of our people who can't get access to primary care. I'm going to speak about the cultural component of the healthcare model, which is relatively new, but it's been around since 1840. So we're just catching up now in terms of our systems change. But before I get into that, I'm going to do a bit of a Michael J. Fox. We're going to go back to the future. So we're going to go back to 1840, and I'm going to do a presentation on the treaty, the impact the treaty had, and then you'll be able to have an appreciation of what is the actual problem we're trying to solve, and then we'll have some solutions. I must warn you, it is quite a bit of a tearjerker, and it does have a negative feeling for some people, but that does end with some positive stuff. So I'm just giving you a heads up. We're going to go old school negative, we're going to move forward, and then we're going to connect you to what the model does, and then I'm going to give you some top tips that I've heard from around different places that I've presented this to. So we're just going right click there, Jess, is it? Oops. No, left. There we go. So the first thing we're going to start with is the Treaty of Waitangi. Hopefully everyone knows there's a Treaty of Waitangi. It was signed on the 6th of February in 1840 up in Waitangi, up in the far north. Now, why I start there, not many people know this, but by the way, if you're going through Cornerstone accreditation or you're about to get healthcare home certification, you should take photos because this really looks good for your reportage. Not many people know, but there was actually 3 treaties that were signed, and one was written in English, one was written in Te Reo Māori, and one was translated from Te Reo Māori into English. Now, if you haven't read those, I would encourage you to, because they only go to about here if you're reading the documentation. If nothing else, read the 2 English versions, and then you'll find that there is a distinct difference in interpretation. And that is a good start on your journey in terms of understanding the treaty. So how I'm presenting this, if you're at a PHO, this is good for your sort of PHO workforce development. If you're at a general practice, this is also good for your general practice. Now that's going to annoy me. I might just do, oh yeah, we'll go.
The
big push the button.
Yeah. The cross.
Escape.
Yeah.
Okay, so the 2 key differences in the treaty. One is on land ownership and one is on governance. So if you hadn't read the treaty, or you weren't there, or your ancestors weren't there, then one is around the ownership of land. So in Māori view, they were saying, please come to New Zealand, no mai haere mai, please share land openly with me, please bring your cousins, and we'll kind of share this land together. That's what Māori view was. The Crown's interpretation was, chebo for the money, for the land, we might just keep it because we didn't have enough back home, so we're going to keep it for ourselves. So that's a sort of a sort of easy way of interpreting the difference of opinion there. The second one was around governance. So Māori view was, please bring the Queen into New Zealand and let her self-govern over all of the people from England. We would like to have our own governance model because we've already been here, and we're allowing you into our space, so we're kind of sharing our governance with you. And the third was around having Māori having exactly the same rights as what the Queen's subjects got in England. Now back in the day that was probably a good deal. As it turned out, it didn't turn out exactly how it's described there. But you need to have an understanding because If you didn't know this, a lot of people think, well, hang on, this is an old document, and there was a war and you lost, so therefore in every war you should just give the land to the Crown or the Dutch or the Spanish. But we didn't actually lose a war if you're Maori. We actually had a treaty, like Japan did in the war, like Germany had in the war, like America had in the war. And we agreed to have a legally binding document which would set forth the progress of our nation going forward. Now, what followed, this is an international proven model, so colonisation has come in. Now, I'm going to show you some actual laws that were passed historically. So in 1863, 23 years after signing a treaty, there was a law passed that allowed the government to confiscate land with no valid reason. So based on the articles of the principal treaty that said, actually, no, we'll actually share land, you have yours and we'll have ours, to come along 23 years later and say, well, actually, you're going to confiscate our land, it's probably a little bit unfair, and it was not taken well. In terms of, from a health perspective, some Indigenous nations like Native Americans, they have tobacco as part of their culture. Some islands have kava, and alcohol is part of their culture. But Māori never had an equivalent of tobacco or alcohol. So when those products were introduced, they were quite addictive. I had a couple the other day, that's how addictive they are. But so as a consequence, our bodies weren't used to those products. They did have a negative impact on us. Also, sugary foods. We didn't have a lot of sugary foods back in the day. So diabetes and cardiovascular disease and diseases like that our bodies weren't used to had a negative impact on us through introduced foods. And then the flu, because we hadn't been exposed to the flu, we hadn't built up immunity to flu. So these are some of the introduced health issues. Back in the day, when I was at school, I used to laugh at this. Like my friends used to say to me, "Bro, what are you complaining about? You got your land back." Like if I had $1 for every time that someone said that to me, would probably clear the GDP debt. But when I looked into it and I became more learned, actually the land wasn't given back. It was illegally confiscated, and Queen Victoria's law said it was illegally confiscated. And if I stole your car, the law says you either return the car or the value of the car. So it wasn't given back. And so in terms of the financial payments that iwi have, it's about 2% of the value of the economic asset that was lost. There's no legal principle in the world where you're not reimbursed for the amount of loss that you've suffered. So when people say to me now, "Oh, bro, you got your money back," I say, "Well, actually, bro, you gave me 2% of the value of my money back 150 years later without interest, and then I had to buy my land back." So no one actually physically gets land back with treaty settlement. So I was trying to dispel that myth. But generally speaking, Māori only through their settlement process only got 2% of the value. When you look at that for Tainui, just as an example, $18 billion worth of lost assets, they got 170 million back. Now, if you had that amount of money for 150 years, you would have to say you would have invested a little bit more in your people through housing, employment and education had we had that 150 years ago. So I just politely remind people who say, "Oh, it's not really my problem." Well, it's actually all of our problems, because this is what was created, not by anyone in this room, but some people before us created this issue. So I'm just building awareness to say, well, actually, that's some of the stuff we're trying to sort out. This was a particularly unfriendly act. 1867, it was illegal for Māori to speak Māori. I have a uncle who's passed away now, but he went to school when he was 5, and he asked in Te Reo Māori to go to the toilet. He got the cane 4 times for speaking Te Reo Māori. He then wet himself and got the cane 3 times for wetting himself. So he didn't speak for 3 years because he thought he was getting the cane for speaking. He didn't realise it was actually associated to his language. Now that's one generation before me. That might be 1 or 2 in this room, or that generation. But that act was around for 100 years. Could you imagine if you could not speak your language in public for 100 years, the negative impact that would have on you and your whānau and your community? So once again, I did tell you it's going to be a bit heavy. It does get positive. So yeah, that was a major oppression for Māori people with respect to the language. This one, Tohunga Suppression Act, 1907, pretty much made it illegal for Māori to practice spiritual healing. Now the logic was we should focus on evidence-based models, and that was the thinking of the time. But we now know, and I think someone mentioned it this morning, we now have wharitapa whā, which is by Sir Professor Mason Drury. If you've studied in the mental health space, you know it's around your wairoa, your hinengaro, your tinana and your whānau. So that's actually wider than just a physical intervention that's required now to look after whānau. And now I find it ironic that 100 years later, I'm talking about the positives of using Māori wellness, well-being as a health model, when 100 years ago it was actually illegal to practice in that Māori space. This one is a particularly hard one. In 1907, when the Plunkett Society was first incorporated, they were prohibited from looking after Māori babies. They were prohibited from immunising them and providing good health care. And that act, unfortunately, did not change for 70 years. So when you think about how hard it is to get our Māori mums to get Māori babies immunised, next time you chuck a comment going, oh, those typical young Maori mums, what's going on there? Just have an appreciation. They haven't had 2 or 3 generations of mums and grandmothers and great-grandmothers telling everyone how positive Plunkett is. So you're going to have a lot of people who actually weren't connected to that sort of Plunkett system. You're going to have a lot of people who hate Plunkett because they're going to associate them not being able to see Plunkett with this act. So yeah, that one is particularly hard because immunisation rates for Māori are not good in some areas. And a lot of people say to me, oh, it's your problem, Arts. Your families don't want to engage. I just politely remind them of they weren't engaged by the Crown for 70 years and the negative impact that would have had for whānau going forward. Next thing that comes along is urbanisation. Not many people realise that Māori were the most quickest Indigenous nation on the planet to move from rural settings where they previously lived to cities. So most Indigenous peoples have moved to cities, and we've moved for employment, for education. Where I'm from in Ngāti Kuri, the government actually relocated us because they wanted access to the sands. So they physically picked up my 2 generations back and relocated them around different locations. But because of that, not a lot of people realise that we've kind of lost our identity to who we were back in the day. Now, if I relate it to the church values. If you're brought up in the church system, you've got pretty good values. You're quite respectful. You respect your parents. You go to school. You get a good education. Now, because we haven't had that for a number of years, not all Māori, but some Māori are quite disconnected in terms of where they are because of their city base. In fact, census in 2006 said 1 in 6 Māori did not recognise as Māori. They didn't know who the iwi were. And another 1 in 6 actually just wrote far north or east coast, which is actually not a real iwi. So you've got almost 30% of Māori who have no idea where they're from. So they've lost that connectivity to their elders. And then back in the day, our elders would have installed values in us that would have said, look after your woman, look after your babies, look after your own body, look after your land, and look after your whānau. Those would have been absolutely entrenched in us as young Māori growing up. But because we've moved from Whanganui, East Coast, far north, and we've moved to these cities, and we've moved in a time where our language was not well promoted, neither was our culture, we've lost all of this cultural identity. Not all of us, like I'm reconnecting to my space, but when I was growing up, I didn't know about my iwi and my marae and speaking te reo Māori, so some of us do reconnect, but a lot of us have stayed disconnected. So that's under urbanisation. One of the interesting points is 70% of Māori in New Zealand do not live where their originally ancestors were from. So I'm from the top of the island. I don't live there. There's no Wi-Fi. They ride horses. There's no blues team, so I don't live there. But it's a long way from where I live. I'm fortunate that my dad entrenches these things into me, and I live in Auckland. But yeah, a lot of people, if you were to go into a room of Māori, half of them wouldn't be from the location that they're working in. Marginalisation, well, the Asians. Now we know the stuff in the health space, that negative statistics for diabetes, suicide, drug and alcohol, you name it, we've got it. We've got it the worst in the country, except for diabetes. Pacific people have diabetes worse than Māori, but everything else we have the most negative health statistics. It's not just health. We're also not good at employment, incarceration rates, home ownership, participation in voting, gangs, domestic violence. We're not good in that space either. So this stuff is known to us. Like this shouldn't be, these two slides shouldn't be new to anyone in the room because they've been there for about 50 to 100 years. One thing I always like to remind everybody in health is we have an act called the New Zealand Public Health Act. We're all bound by it, so everything we do, we must comply with it. The section 3.2b or 3.1b specifically says that everyone in the healthcare system needs to prioritise Māori and other important populations when they're looking in the health space. So we actually all have a legal obligation to ensure Māori are being better off. Some of us do that. Not everyone in the healthcare system, I would say, does that, because otherwise why would we have those negative statistics that I put up previously? Not only is it an act, this is a copy of a contract. If you're a PHO, you'll have a marginalising contract with your DHB, and one of the clauses will be to say that you need to focus on the treaty. So even in your contracts that you're delivering against, there's a treaty requirement. Now, not actually many. Now it's in clause 1 and 1.3, so it must be quite important. But not many people actually know what does that actually mean. I have a treaty obligation under the contract and the work that I do. So part of this is actually the awareness on what that means. I'm just going to quickly touch on life expectancy. This is probably the best indicator, I think, in terms of determining the overarching health and well-being of a population is life expectancy. So this goes back all the way to 1950, and then so the dark lines are females and the dotted lines are males. Orange is Māori, red is non-Māori. So there's been a categoric discrepancy in life expectancy, Māori versus non-Māori. They've just recently added Pacific for the last 50 years. Now there was a bit of a positive blip, but we haven't really changed much. So you'd have to say, and someone said it this morning, if you always do what you've always done, you always get what you always got. That's a good example of that, because we haven't really changed stuff. Which is why I like healthcare homes, because healthcare homes is a behavioural change to change some of this thinking. Diabetes is the same. As I mentioned before, Pacific and Indian people actually have diabetes will be an absolute nightmare in the healthcare system for us. So notwithstanding the treaty stuff for Māori, diabetes for Pacific people is an absolutely train wreck, particularly in Auckland, particularly in counties Manukau. And it has the ability to cost, I think it was $3.5 billion I saw the other day. There's a colleague of ours in primary care. He's saying in 25 years of trying to change the needle on diabetes, we haven't moved a millimetre. So for all the good work we're doing, we haven't actually done a lot to address diabetes, which is one of the -- 1 killers for our people. Now, bowel screening, a particular hated favourite. The evidence is that, says that there's 60% of female who are Māori and 50% of male are more likely to get cancers younger than 60, and yet we have a 60 screening age. What I say to some of my colleagues is, could you imagine if we weren't going to reduce the rate for Māori by 10 years, should we increase the screening rate for non-Māori by 10 years? Could you imagine how well that would not go down? But it's the same unfairness in terms of a healthcare system. So most of us in this room have actually signed a petition to say that is rubbish and that needs to change. So that's the positive stuff. But it's still not a priority for the government to address that, even though there's categoric clinical evidence that says that Māori should be screened at a rate younger than 60 years. Now, if that doesn't scream racism, evidence-based, I'm not sure what does. So we still have this rubbish that goes on, as recent as last year. I'll just skip that one. But in terms of COVID, so COVID, we've got historical data based on flu and the 1918 Spanish flu. COVID, unfortunately, will have a more negative impact on Māori and actually Pacific than non-Māori, non-Pacific. So when we see some people in the news saying, well, surely Māori should be categorised higher than maybe an over 65-year-old person, that's what that debate's around. It's around, well, we don't want to not screen over 65s, but on a risk profile, Māori are actually more at risk than non-Māori over 65. So it's not that we're being mean or mean-spirited, it's just that the data supports that Māori are more likely to have a negative impact from COVID. In terms of the 209 influenza, Māori were 3 times more likely to be hospitalised and 3 times more likely to die from exactly the same disease. So there's something in our DNA that's not good. There's probably some historical DNA stuff there. In the influenza flu, we died at a rate of 7 to 1 to non-Māori. So when you see Māori closing the borders and putting up roadblocks up in the far north or in Whanganui or Whanaopanui, and they don't want tourists coming in, they're not doing it to be a pain, they're doing it to protect their communities, because if that gets to their communities in a rural environment and we don't have enough rural workforce as it is, that will be disastrous. But the media portrays it as, oh, Māori blocking the roads and they're breaking the laws, and what are they doing? Well, they're just actually trying to protect their communities. This is an interesting slide. I first got this when the pandemic first hit us. Effectively, it says these 4 waves to a global pandemic. Now, fortunately, as that would, yes, fortunately New Zealand didn't get the 2nd, 3rd or 4th wave. Sorry, we didn't get the 2nd or 3rd wave, but normally in any pandemic, it's flooding of the hospital system for people who are impacted directly by the pandemic. The 2nd wave is all those people who got bounced. Remember, they closed the hospitals for about 3 months? All those people who are on waiting lists, that will now create a health issue for us because of the delay that had. Now, it wasn't a huge delay, but it's still a delay. And the 3rd one is people with chronic diseases who then got bounced from the 2nd one are now pushed out. Now, we know that Māori we know that Māori are the most impacted negatively, and we probably know that they're the least likely to access primary care. So if you did an equity or a Māori lens over that diagram, it would actually be worse for us. By the way, just out of interest, the biggest impact from a pandemic is mental health from burnout from our clinical workforce who just have worked day in, day out over a pandemic, and then the burnout for people who have lost jobs, stuff like that. So that's still to come. I think we're seeing it from a financial point of view. We haven't yet seen it from a mental health point of view, but there'll be a massive peak in mental health issues in our country. Racism, it's one of my most at least favourite words. We probably shouldn't deny that it exists. Like, to say it doesn't exist, you're kind of putting your head in the sand. There's a couple of examples up there. About 3 years ago, a Maori male stole 10 fish to feed his family, and he went to prison for 12 months. And that within a week, there was about 6 non-Māori kids who trashed a house, caused $200,000 worth of damage, and got home detention. That doesn't seem to be fair relative to that issue. We've had people in Hawera wearing blackface. You know, blackface is a mockery of slavery and black African Americans being hung from a tree. Like, for us to celebrate that as something that to be proud of, I don't think that's appropriate at all. Who here has, just out of interest, who here has heard about the land wars for Waikato in 1860? Anyone here heard about Orake occupation at Bastion Point? Were they there for about 500 days? What about Parihaka? So that's probably half the room. There's probably a few more, but everyone's probably doesn't want to put their hand up because they think I'm going to ask them a question on slavery. But the point I raise is that we're well-educated people in the healthcare system. We weren't taught this stuff at school, and yet it's a key component of our history. It's going to be taught probably in about 2 or 3 years' time, but it's a key component to understanding of what Māori had gone through. So Parihaka was, there was a war, the land was confiscated, then there was a tax against Parihaka people for the value of the war, the cost of the war, and they paid that through land confiscation, and it was effectively slavery in New Zealand society. Now, we don't like talking about that because we think that's only in America and other countries, but that happened in our country. Now, we're not blaming anybody, but there's just an awareness of what occurred and therefore what some of the solutions could be going forward. So here's some photos. You've got some photos in 1923 of people wearing KKK masks going down Queen Street. This is an interesting story. 1974, that's Hori Harawira's wife. She got sick and tired of those engineering students mocking the haka. So she went and confronted them. Now that made the front page of the newspaper. What no one realised is a van full of, I think Honi Harawira that night went back and beat the crap out of all those guys with all his mates, but that didn't make the headlines. But yeah, this is 2018. 2018, you have your Lions Club wearing a extremely racist attire in our country. And then most recently through Ihu Mato. Now that's not a racist issue, but it's an issue that shows that we haven't resolved how we deal with historical land claims in this country. Now that was settled, and Fletcher's is probably happy they got a $30 million cheque for that. But it does show that there's an underlying issue that New Zealand just hasn't dealt with. And if you're Fletcher's, you're right because you're the legal owner. If you're the historical owners, you are right because you were given the land from the council. If you're Maori, you are right because you were the original owner that was confiscated. So you've got three people who are right and only one piece of land. But we haven't nailed down that pricing mechanism, and we're only fortunate that there was some money left over in Kiwi Build funds apparently. Here's a really bad one, right? So we all go to war, and all our returned servicemen, we all fight together, we all die together. Every non-Māori service person returns, they get a job, and they get a package of land. That was not offered to Māori who fought in the war overseas. None of them were offered the same things. Now, we didn't get to vote until 1893, but we only got to vote because a woman got to vote. So we changed the rules in 1893 to say anyone who owns land in New Zealand is entitled to vote. And because women owned land, they could vote. And because Māori owned land, they could vote. But we're in our country for about 80 years and we couldn't vote on our own country. Wildly odd. Now this is a generic, this is quite generic, but it's quite evidence-based. So in the healthcare system where we all are, if this was a primary care intervention, now it is generic, but I do have data that backs this up because a lot of people question this one. Non-Māori generally own a motor vehicle, which means they could get to the clinic okay. A lot of Māori don't own a motor vehicle, so transportation is an issue. They can, normally their boss is nice and lets Māori go lunch break for a general practice appointment. It's nice. I've got evidence that a lot of solo mums who are working in warehouses, they're not allowed to take off lunch break. They've got to take unpaid leave or annual leave to take themselves or baby to the doctor. In general, I've had a lot of feedback that non-Māori are greeted really positively at general practice, but I've had a lot of people met when I've done surveys to say they're met with a question like, "Oh, are you married?" And they're like, "Oh, no, I'm not. No, I'm not," because you've just assumed something, and therefore I feel like I'm being intimidated, so I won't self-identify today. Generally, there's an awareness through health literacy of medical interventions. Unfortunately, a lot of Māori have low health literacy, so they're not aware, and we actually talked about it this morning through the patient portals. They're not aware or self of how to navigate through the healthcare system. Generally, our whole process is someone like me. I've probably got diabetes. I'm a smoker. I'm a drinker. Probably overweight. I'm a 40-minute console. Now, economically, I'm not seen as convenient in that funding model. I don't smoke, by the way. The Māori might have an issue with affordability on copay. We do have very low cost access, but some aren't in that space. And then, unfortunately, a lot of Māori don't pick up medication. Now, e-prescriptions has made that a little bit easier, but some people can't actually afford the $5, which is quite sad. So we're going to pause. So that's all the negative stuff. So we can kind of take a little bit of a breather there. So what's some of the positive stuff we've got going on in the Māori space? We've gone from a space where Māori language was made illegal for 100 years. We now in this country have 3 wānanga who are treaty-based and Māori operated. Wānanga of Aotearoa, wānanga o Raukura, and whare wānanga o Awanui. So those are actually Māori universities. So can you see the polar extremes? We've gone from having a league, and we've also got land revitalisation. These are some predominant Māori organisations that we are proud to have in this country. The bottom ones are national organisations. Everyone knows Scotty and Stacey. They're on every Māori thing you could think about. But they're revitalising the Māori language. So this is what can happen when you actually put some resource and dedication behind it. In the health space, so we have very low cost access. So I think it's $19.50 at the moment is the VLCA practice. Some are $10, to go to the doctors. Community services card now has been loaded. That doesn't matter what clinic you go to. It's $19.50 that can follow you around. It's free for under 14, free dental for under 18. There's targeted funding through SIA and Care Plus for Māori and Pacific and Quintile 5. Hospitals are free. Could you imagine living in America right about now, going to a hospital with COVID? And if you have an accident at your workplace, sports field, or at home, a company that has about $50 billion called ACC pays 80% of your salary. So that there is a very good healthcare system. It's probably a world-class healthcare system. The issue we have is there's a whole bunch of people that can't get into it. Once they're into it, they can't navigate through it, and some of them can't pay for things in it. So it's not the overall health system that's wrong, it's just the access points. People laugh at this slide. So at one point in New Zealand's history time, Calvin Davis was the deputy leader of Labour. Marama Davidson was the co-leader of the Greens. Winston was the leader of New Zealand First. Yes, believe it or not, David Seymour was Māori. He's the leader of ACT. Simon Bridges was the leader of National Party. Paula Bennett was the deputy leader, and JT and Debbie were the co-leaders of Māori Party. Now, I didn't say they were good leaders, I said they're prominent leaders, just for clarity. But at one stage, every one of our political parties was led or co-led by a Māori person. So can you see the positive shift we've had from all the negative stuff I've had before? People laugh at the David Seymour one. In terms of today, this is actually how many Māori are in government. You've got some in government, some in parliament. So I think Labour has 15, ACT's got a couple, National's got a couple. What's today? Right, yeah, they've got a couple today. Māori Party's got a couple, and Greens has got a couple. So that from not having any representation on government, not being able to vote, not being able to have governance over your own land, historically to that model there, that's pretty outstanding. And the reason I give this as an example is because could you imagine what we could do in the health space if we changed some of our thought processes. In terms of ministers, there's a whole heap of ministers who are Māori, and the ones that aren't Māori are pretty pro-Māori, like Andrew Little. He's a Treaty of Waitangi negotiations. That's a pretty important job. But Nanaya, Calvin, Penny, Willie, Kiri, they've all got ministerial portfolios. That's a proud moment if you're Māori. Well, it's a proud moment if you're New Zealand, but it's also a proud moment if you're Māori. It's not just in politics. We've got some outstanding leaders. I'll just pick out a few. You've got Dame Whina Cooper, Dr. Peter Sharples. I politely remind everybody, Mike King, Taika Waititi, Lance O'Sullivan, the last 3 New Zealanders of the year, we're Māori, just putting it out there. But it shows how far we've come that we can appoint 3 people who are Māori as New Zealanders of the year, because we look past the Māoriness and we see them as good people. Ironically, when you come out as New Zealander of the Year, you talk about racism, because that's what all 3 of them have done. This lady here, Dame Nita Glavish, she was the Kia ora lady. She got sacked for saying Kia ora when she worked for the phone company. She answered the phone with Kia ora and got, the tolls, yeah, wouldn't have been Spark back then. But she got the sack for saying Kia ora when she answered the phone. She's now the chair of Ngāti Whātua and also the tikanga manager for Auckland and Waitemata DHB. This lady was the first lady who invented kohanga reo for us. Then some Mason juries up there, Whaitari. There's a stormtrooper up there from Star Wars. And some people who sang the national anthem in Te Reo Māori and were shunned at the time, but now it's just all part of what we do. So what does it mean for us as a group of people in the healthcare sector? So this is actually ProCares, I've just changed the name, but incorporate Māori values to your organisation. So if there's 3 principles, how would they apply to your organisation at a PHO or at a general practice level? It could be something really easy, or it could be something really sophisticated. You will start your journey on the treaty, recognition and awareness, on your own terms, and it's just a starting point. No one's going to knock you back for being wrong on stuff you've done historically. Just acknowledge things could be done better and just make those positive changes going forward. There's no historical police. Actually, when I was at Procure, so one of the first things I did is I wanted to ensure we had strong treaty relationships with our organisation. And to be fair, they weren't strong prior to that. Now, I guarantee up and down the country, there's not many organisations who are strong with their treaty partners. So I was able to get Steve, our CEO at the time, he's left, but Ngāti Whātua and Waipareta in the same meeting to positively have a conversation. Now, if you know the history of Auckland, that's a historical photo, that one there, just quietly. Also did the same thing with Tainui. Now, there were some issues historically, but we got in a car, we had a conversation, we agreed to work together more positively going forward. We did acknowledge some negative stuff that occurred, but we've moved forward. So I encourage large organisations, if you can, to reach out to your iwi who are in your zone. Who here knows the iwi that they are physically based in, like their general practice or their PHO? Like who actively knows the iwi that they're in their space? So that's one thing, that's a challenge I give to you all, to understand what is the iwi of the space where you work, because they will have different protocols. They might have kui o kaumātua to call on, and if you need, if say your Māori whānau dies and you want to know a protocol, they'll be a good connection. The other one is who here knows the closest marae to their general practice or PHO. Once again, I challenge you to just jump on Google, find out who the local marae is in your space. And what it means is every time you have a conversation, you include Māori and iwi organisations. So in Auckland, and Barbara's part of this with us, is we put like a crazy as bid in for mental health of all the PHOs, all the DHBs, all the Māori providers, all the Pacific providers, and all the mental health providers. But we made sure that the Māori providers and the treaty partners had a really good voice at the table, and it wasn't, can you please just come and add your signatures to the front and do a bit of a mihi on the back and we're all good to go. So we actively included them. They subsequently sued us, but we at least we had good intentions to move forward together. Now this one's a bit of a complicated one, but depending on your appetite for embracing cultural awareness, you could have a cultural competency framework in your organisation, and it could cover governance, it could cover recruitment, it could cover interviews, it could cover policies. Now this is probably level 404, but like if you wanted just a base one, here is Amajit put up a karakia, which is a standing one. Here is a base one that you can get off the internet. This is one we're going to learn as an organisation. We're going to make sure that everyone understands the treaty within our organisation. So once a year, we might print out those 3 versions and read the 2 English ones. Or you could go full on, say actually we want to have a full immersion of Te Reo Māori and tikanga Māori in our organisation. But once again, you determine that. No one else does. Have you read the Ministry of Health Māori Health Action Plan? It's our Māori plan for the next 5 years. It's on the website. It does show a good footprint in terms of where we want to be heading in Māori health going forward. And then the other key one I like is have you read Healthcare Homes? Because in my mind, and me and Jess were just talking about this before, if you keep doing what you've always done, you're always going to get what you've always got. But that doesn't apply when the healthcare system changes completely. And if you keep doing silly, bad, unprofessional stuff in a non-culturally appropriate way, you won't be around to keep doing what you've always been done, because there's not physically enough money in our healthcare system because of COVID to keep funding same. So we've got to fund new. And new is things like Healthcare Homes that just challenges the business model, challenges the cultural model, challenges the clinical model, because if you're not keeping up with where the government's heading, you're actually getting behind. So to the point of doing the same thing, why not actually advance you? So I'd encourage you, because I think this is a good stepping stone. If you haven't gone down this journey, it's a good stepping stone to what's coming in the future, where they're going to say you will need to have more accountability for Māori health outcomes. You might need to have half of your board who are Māori. You might need to have more of your workforce who are Māori. So you don't want it this pushed upon you if you haven't planned for it. It's like you said, someone said it earlier this morning, people that were on the patient portals and digital care were much better prepared for COVID when it kicked in than practices that weren't. And that's probably categorical across the country. And I think it's similar here. Like this stuff will actually be policy in a few years. So if you're not kind of keeping up with how the policy's riding, you're actually going to be left behind. And then just some quick questions I always like to ask, and I think we're circulating these so you can pick them up later, but like how many Māori doctors in your network? How many Māori nurses? Like I knew when I was at ProCare it was only 2% of our workforce was Māori. How many general practice staff in your wider network if you're a PHO? How many of your practices are kaupapa Māori? And then what could you learn from them? And vice versa. How many on your board are Māori? How many in your organisation are Māori? And if you've got some in your organisation, what are their leadership levels? Like, are they high level, low level, mid level? Because that will have it's almost like doing your own little treaty equity audit that you could just do and fill it out yourself. Go, well, actually, we daylight from this stuff. Or actually, no, we're pretty good on most of this stuff. Look at your data. Your data will tell you everything. Your enrolments versus your non-enrolments in your community. IMS, diabetes, CVD, smoking rates, cancer screening. Look at all of that stuff and compare by practice or by PHO what your Māori data says, what your non-Māori data says, and that will show where the gap is and focus on your gaps. And then it's gonna some practices might be tricky, but just focus on one. Focus on one for 3 years, another one for 3 years, and then what's the bottom one? Oh, mental health referrals. Someone touched on mental health earlier. How many of your patients as a proportion are being referred to the mental health model? Because it should be at least 15%, because that's the population. Probably should be 30%, because that's the need that Māori have. And then just finally on this slide, so Māori as a population, we represent 15% of New Zealand, Aotearoa. On any given health day, we're 20 to 30% of that issue. The Treaty of Waitangi says everything needs to be done in partnership. So partnership last time I looked was 50-50. Does your organisation reflect this? And do your organisation policies reflect this? So we've got everyone knows this one, but if we don't, this is a good one to use. He haha te mea nui I te au. What is the most important thing in the world? He tangata, he tangata, he tangata, it is people, it is people, it is people. So that's the sort of treaty 1 hour or 45-minute sort of presentation. But the key to that presentation is hopefully I've made you aware of some tough stuff that occurred historically in our country, and that might give you more of an awareness on why we need to change some of the stuff going forward, and it might change your behaviour to moving from blaming the whānau for not showing up to an appointment or not paying, to having more of an appreciation on what can happen in our communities. Now I do this from a treaty point of view, but this could apply to Pacific, Indian, youth, LGBT community, rural community. It's the same logic. Understand the issues that are facing those communities and then build a solution around that. So I'll leave it on that, and I'll take some questions. Am I taking some questions? Yep. And then I'm going to give you some sort of linkages into the healthcare homes model and some top tips that you can just practically do. So is there any questions on that? I've had a lot of people actually, not a lot, but I've had a few people actually question the integrity of where I got that stuff. That's why I've actually put the links in there. Like, oh no, that's not true. They wouldn't have made your language illegal. I mean, it's an act. You can Google it. It's like one person said, "Oh, it sounds like you're making it look like they deliberately tried to get rid of you." Do you think all of that was accidental? Like all of that, and maybe one, but all of those together. So in terms of healthcare homes, where the connection, the join the dots is in terms of virtual care, the portal stuff. That comes under self-determination. Because if I'm a Māori and I have to go to the doctor because that's the only option, if I've got an option of a phone, or I can log on to my own data, I can manage my own data, having that kiosk when I can choose, because frequently people are asked in an inappropriate way some data, so they just switch off. They go, I don't want to give you that data. But when you're filling out yourself, you're not going to lie about yourself, so you've got to be more honest and open. So I like that. The extended hours is good, because a lot of whānau work in manufacturing jobs from 8 till 5. If the practice is closed at 5, how are they ever going to see primary care? So having extended hours is very helpful. I had a personal one where I had an ear infection. It was like week 1 of COVID, of course it was. And then I ring up and I just say, I need to see the doctor. Do you have a cough? He said, I've had a cough for 5 years. Okay, well you can't come in because you've got a cough. I understand that. The doctor will ring you back. And then we played phone tag for like 3 hours. Doctor says, do you have a cough? I said, yes, I have got a cough. Oh, you can't come in because you've got a cough. I'm like, did you not talk to the receptionist 3 years ago, 3 hours ago? And as it turned out, though, it was a positive story because I said, hey, the medication you gave me 6 months ago didn't work. The one you gave me 4 months ago was really good. I just want that one. Oh, great. I'll do an e-prescription. I'll send it to the pharmacy you want. And that's only $19, not $44. So that was a positive for me, not the 3 hours of waiting back and forward. So when you, because we physically don't have enough doctors and nurses in our country to look after all our people, then having something that's digital is definitely a good for whānau and for the clinician because it's less time. And then for me, I didn't have to go and sit in a waiting room. Someone said that their doctor's 20 minutes late. Mine's like an hour late. Like even if you book the first appointment, I'm like, how does that work? But then how it works is I go to there and then he actually gives me health literacy for about 45 minutes on what's wrong with me. I'm like, actually, no, I get it. I get why you're late at the end of the day because you've spent 40 minutes with every person. So I can't really tell you off for that. So one of the key things in the Māori space, or there's 4 key principles we have in terms of our engagement. One is, the first one is whanaungatanga. So that actually just means building relationships. Now, that is one of the most important things to do in the Māori health space. So if I don't get on well with you as my doctor or nurse, I won't listen to the nurse, I won't listen to the GP, I won't get my medication, and I probably won't want to come back and see you again. So ironically, one of the most important people is the front desk person. So if they're approachable, if they pronounce my name correctly, if they say, oh, kia ora Lance, your appointment's half an hour late, and they're speaking to me professionally, I'm going to be way more engaged. So if you're in the health space, and we all are, I can't overestimate the importance of front desk training on relationship management. Pronouncing names correctly, putting it in your in medtech in one of the non-printable lines, you could phonetically write the name. So you write it how it's said. So when that person comes in and it pops up on the screen, you don't know how to say it, but you've written how it's said, and you ask them how it's pronounced firstly, and then you write it in the system. That's a key one. You might have like a red flag of the kuia or kaumata who's really, really entrenched in their culture. So you might say this person is always greeted with a kia ora or a tēnā or a malo, depending on your ethnicity. You might also have, in Māoridom, it's sacred to touch head, take body parts and stuff like that. So if you were seeing a kuia kaumata, you might suggest that, should we open with karakia before I take your blood, before I remove something from your body? Now, half of us will say, no, don't worry about it, we're not into that. Half of us will say, thank you, I really appreciate that you took the time to respect my culture, I'm now more aware. Now, 101 in that instance might be, could you do the karakia before we start? Now, the next iteration might be, I'm learning karakia in my general practice, could we read this one out together? The third one is, I'm quite culturally competent, I'm going to do karakia because I'm aware that you want to start with karakia before we do our intervention. So that's a little top tip. So the first one is whanaungatanga, or just building. It's like if you go to a bar, you just don't go up to someone, buy them a drink and get into it. You have a conversation, you build up to an intervention, or it's kind of cool intervention, So maybe scratch that one from the thing, But the key is you're building rapport and trust. So if we trust you, we'll listen to you. If we don't trust you, we'll never listen to you. So that's the first one. The second one is needs assessment, which could be done by nurse, healthcare assistant, because not everyone is coming to hit your KPI on a smoking cessation target. They actually have other health issues. So ask them what other things are going on, not just what you're in here for today. So you want to build up a bank of the 5 or 6 things that whānau might have on the go at the moment. They might not all be health related. The third one is actually, if I came in and you fix me, please fix me. Don't cut my left leg off, not my right leg. Sorry. And the last one is, if I came in and I told you that I was having issues around drug and alcohol or budgeting or something else other than what I was saying today, please navigate me to someone else who can help me. So the evidence is that 20% of someone's health and well-being is health, 80% is a social determinant. So it doesn't matter how good we are in health if you don't do the social determinants, and it could be family violence, drug and alcohol, budgeting, could be unemployment. Have a list or a spreadsheet of all those services that are available for whānau to access, and that's how you're really going to help them. So those are the 4 key ones. I've had a doctor say, if your whānau know, and I've created a safe space before he said this, if all your whānau know how bad smokes are, how come all your Maori smoke so much? Which was a good point. I didn't like the way he said it, but it was actually a good point. So I had to explain to that doctor, well, and I kind of did a 5-minute version of that treaty presentation. I said, a lot of my family have gone through some historical trauma, and they're suffering, and they're still suffering, and there's domestic violence at home. So a smoke for them is their go-to. So, you know, who are you or me to tell them not to smoke when it's a smoker or hiding? You know, so rather than asking it that way, maybe you could ask the whānau, what are some of your whānau goals and aspirations? And when they say to you, oh, we want to live longer for our wokapuna, you say, well, how do I help you be healthier so you can be there for your babies? So maybe just ask that question in a different way. I've also had a doctor ask me with my Pacific manager, why do all your islanders eat KFC if it's so bad for you? My first response was because it tastes so good, but the actual response was a lot of our Pacific families just live week to week, so they don't know how to budget. They don't realise that if they put away $120 a week for groceries, they can go and buy twice as many groceries. They're working day to day. It's easy to give your kid $5, and there's a bakery next to every school that sells a pie and a Coke for $5. So don't blame the family, blame the person who put the bakery next to the school. So once again, there's more awareness. Some people say, why do we even talk Maori language? And I said, well, firstly, it's the first language we have had in New Zealand, so that's nice and positive. And secondly, it's actually an official language as a sign. And I politely remind them, do you ever complain when the person's doing sign language next to Jacinda? No, it's the same thing, you know. Is it really annoying you? Like, just change the channel. It's really easy. It's Scotty, you know, all this, like Scotty gets complaints. Oh, this is a good one. I only get funded for 15-minute consults. How can I do 40 minutes or even an hour? So my response to that is twofold. Firstly, 4 whānau consults at 15 minutes each is 1 hour. So you could do 4 consults together as a whānau for an hour and do all those interventions together and then claim through PMS system 4 times. So you could do an hour conversation. Secondly, you don't get paid 15-minute as a subsidy, you get paid 2.4 times through capitation. Doctors are funded for 2.4 visits per annum as a subsidy. So if your patient is going to your doctor 6 times or 8 times, you are actually personally subsidising. That's digging into your profits because the government only pays you 2.5 as a reimbursement. So aren't you better to get that person healthy so they only come to your general practice 2.4 times, not 6 times, and actually cost you 4 visits? So sometimes you've got to explain the financial metrics behind moving to 1 hour consults. The other one is if you do 1 hour consults and I came once a year, isn't that better than doing 10, 15-minute consults because I'm not being fixed all the time? So sometimes you've got to challenge that logic. Another good one is why don't your families get the vaccine? Yeah, I've vaccinated, and I revert them to that Plunkett one. I use that a lot. But it's not only Plunkett, it's there's a lot of AntiVex material out there, and our families are scared. Some of them have lost jobs through retail or tourism, so there's no money. And when you don't, in the absence of good health data, then you're relying on this stupid Facebook anti-vaxxers and then that's the only message you're getting. We don't really have an anti-vax campaign in New Zealand. We kind of tolerate it and we say, oh, that's all wrong. Don't listen to that. But we don't actually say, no, it's completely wrong. Never listen to it. Never put any of that stuff in a journal. Never put anything on TV. We kind of just tolerate it under free speech, but really it's dangerous speech. So that's a good one. Those are some questions I get that quite often people want to ask, but they go, I don't really want to, especially that, how come all you married smoke? That one's a funny one. But yeah, your equity journey is whatever you choose it to be. But I got to say, the health and disability review changes. There's a treaty claim in health. Everything going forward will be about improving Māori health outcomes. It'll be about connecting to treaty frameworks. It'll be about having more Māori in the workforce, and that will actually come as policy in the next 2 years. So if you didn't think I was saying the right thing, just watch what Andrew. There's going to be a Māori Health Authority, which is effectively like a Māori DHB or a Ministry of Health. I don't want to use those words, but you know, so it is coming because we can't keep having that stuff. So if you want to get ahead, healthcare homes is actually a good stepping stone because it's starting your behavioural change and stuff like that. If you want to stay behind, it's all good, but you might wake up and find that you are not an economically, financial, sustainable business because you won't get funding anymore because governments will start funding positive outcomes rather than just widgets and gadgets because there's physically not enough money in our healthcare system. Someone's got to pay for the COVID stuff. Might be the tax, the capital gains tax. Because my goal is so I'm in the mainstream space, and the reason I'm in the mainstream space because only 2% of my whānau go to Maori tikanga practices. So there's no use in me going to marae and a iwi giving them this presentation. I'm going to get more use out of hopefully providing awareness to non-Māori kaimahi who then have a bigger impact on a Māori population in the healthcare system. So that's where I've kind of positioned myself. Because hopefully you learned something today. Yeah, awesome, thank you.